Welcome. It's nice to see the sun back after a brief spite of rain. I'm going to go ahead and get started. I'll start with our Ramatish Ohlone land acknowledgement, and then I'll move on to introducing our speaker. So I'll just read it out loud real quick. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramatish Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land, and in accordance with their traditions, the Ramatish Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretaker of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the elders, ancestors, and relatives of the Ramatish Ohlone community, and by affirming their sovereign rights as First Peoples. Okay, so I am so excited to introduce our Grand Round speaker today, who we are so lucky to have speaking for us. So Dr. Amy Gelfand is an associate professor of neurology here at UCSF. She did her BA at Dartmouth, Harvard for med school, and then has been here ever since. One of those you can stay forever, was at UCSF for residency in peds and child neurology. And fun fact, we were actually in residency at the same time. So we've known each other for a really long time. And then she did a fellowship in peds headache medicine. And Amy, correct me, but I think you were the first ever person to do a headache fellowship, and you kind of created it?
At UCSF.
At UCSF.
Yeah.
I remember that, and is certified in a subspecialty of neurology of headache medicine, directs the child and adolescent headache program here, which is actually the only peds headache program in all of California right now. So we are very lucky to have peds headache here. She's a member of the American Headache Society, the International Headache Academy. Amy, I was reading through all of the places that you have spoken. You have quite a passport sort of stamp collection going. She's given talks in Copenhagen, Taiwan, London, and Turkey just in the last couple of years, all in a headache medicine. And then my favorite fact is that Amy's the editor-in-chief of the Headache Journal of the American Headache Society, and she is the first ever female to hold that role. So that is a great feather in the cap of us all. So we're really lucky to have her speaking to us today on pediatric migraine management.
Well, thank you so much for that warm welcome. And it is such a pleasure to be here talking with you all about my favorite topic, kids with headache disorders. My disclosures are here. I don't think any of these are relevant to today's topics. If I'm showing a picture or a video of a kid, their parent or guardian has given permission for that use, and I will definitely be discussing off-label treatments, and I'll highlight which ones are off-label, which ones are on-label. Objective-wise, I'll tell you right now, the one that I really want to make sure that everyone comes away with is feeling number 3, feeling comfortable prescribing oral sumatriptan to an adolescent with migraine. If you come away with just one thing, I hope it will be that you feel like you can add that to your practice and feel comfortable knowing when and how to offer a triptan to an adolescent who has migraine. So first things first, the goal when you're seeing somebody who's having recurrent headaches is to come to a specific diagnosis, a headache diagnosis. And in headache, we use the International Classification of Headache Disorders, currently in its 3rd edition, ICHD. This is analogous to DSM in the psychiatry world. And it contains hundreds of different headache disorders, some of them primary headache disorders, such as migraine, tension type headache, cluster headache, others secondary headache disorders. So this would be headaches that are secondary to head trauma, to having a systemic viral infection, to having a central nervous system infection, or high pressure or low pressure from a CSF leak. So really our first job when we're seeing a patient is to sort out, are we talking about a primary headache problem or a secondary headache problem? And within those categories, which one are we dealing with? And I'm showing the diagnostic criteria for migraine. I've highlighted in red the features that are different for kids and adolescents compared to adults. Migraine attacks can be shorter in children, as short as 2 hours untreated or unsuccessfully treated, whereas in adults, that lower margin is 4 hours. The location of migraine headache is much more often bilateral in kids. And this is true actually all the way up through early 20s. Over 80% of young people will describe bilateral head pain with migraine, most often bitemporal or bifrontal. And particularly for younger children, they don't necessarily need to be able to articulate that they're sensitive to light or sensitive to sound. We can infer that from their behavior or their parents' description of their behavior. If they want to go into a quiet room and lay down in the dark, those sorts of things can tell us that they are experiencing photophobia and phonophobia. And then every ICHD diagnosis ends with this, not better accounted for by another ICHD diagnosis. And it feels kind of throwaway, but it's not. It implies that we've done a really thorough history. We've done a good neurologic exam, ideally including fundoscopic exam. And we know that there's nothing signaling for a dangerous secondary headache disorder. Tension type headache, the features, the diagnostic criteria here don't differ between kids and adults. And I think that's probably a matter of under research. I think if you dug into it, probably things would be a little bit different. But essentially, think of tension type headache as featureless headache. Migraine has features. There's sensitivity to light, there's sensitivity to sound, there's sensitivity to movement, there's vertigo, there's confusion. There's all kinds of brain-based problems going on with migraine, whereas tension type headache, it's just pain, and it's not severe, generally speaking, and there's no other features with it. So how do we actually operationalize this to get to a diagnosis? And for me, headache is all about history. It's really, this is why we staff the fellows in the room, and so that we can really hear the whole history and make sure that we've got all the details straight. So the best thing about pediatric headache is that you've almost always got a parent or caregiver in the room. They can tell you their own first degree relative history of headaches, and they know the family history of headaches very well. And they can also remember things that the patient themselves can't, like little infant childhood periodic syndromes. Were they colicky as a baby? Did they have abdominal migraine or episodes that would be concerning for abdominal migraine? So there's a lot that's really quite useful about having that parent's input on the history. But it can also be a really big challenge in headache history taking, that you always have the parent in the room, because often in their unbelievable abiding love, parents want to give the history, but it's the kid's head and it's the kid's body, and they know best what's going on. And if you don't have an organized approach, it can feel like you're drinking from a fire hose. There's just so much information coming at you in a random order, and it's very hard to organize. So it's really helpful to have a systematic approach to headache history taking. So this is how I do that. First of all, we assign seats. It's elementary school style. I put the kid closest to me, and you can do this on Zoom too. Just have them switch seats if they weren't closest position, so they're not out in the blur. I hate it when the kid's out in the blur. You got to be able to see the patient. So I put the kid closest to me and the parent to the side. This is a nonverbal signal that this conversation is going to be predominantly between me and the patient, and the parent is there for support. And then I take 30 seconds at the top of every new patient visit to set expectations. If I ever skip this because I'm feeling rushed, I end up really regretting it, because halfway through the visit, I'm getting information in random orders, and it's hard to organize. So it's really worth taking the 60 seconds here, or 30 seconds. I say, okay, I'm going to ask you a number of questions about the headaches you've been having. I ask my questions in a certain order because it helps me to think through the problem. But if there's anything I don't ask about that you think is important, by all means, add that in. But I'm going to be asking these questions to you, young Paddington, because it's your head and your body and you know best. However, I don't want that to be stressful. If you can't remember which doctor said what when about which medicine, you can always phone a friend to your mom or your dad. I can tell they're here. You've got great backup with you. And that tends to help everybody relax, know that I've got a plan, I've got an approach, we're going to go through things systematically. And I think it also sets the expectation that the kid can ask the parent for help at any point, but the parent should hang in there and until later in the history taking if they want to add something. My mentor, Peter Goadsby, has this axiom that good headache histories are taken, not given. And the longer I'm a headache doctor, the more I agree with that statement. So I think it's really helpful to develop your own approach. It doesn't have to be the same approach that I use, but get yourself a way that you feel really comfortable going through a headache history. And then we just take the history and walk through all of these features. I think it is most helpful to ask the patient about when you have your most severe headaches, because maybe they have some that are mild and some that are moderate and then some that are really severe. And when it's severe, that's when the features tend to come out. So when you're having a really severe headache, do lights ever bother you? When you're having a really severe headache, do sounds ever bother you? And that can give you clarity about what you're dealing with. Kids, again, they might be able to articulate their symptoms, and I think they are actually very good historians if you can give them understandably phrased questions, but they could also draw it. So here, this is a nice drawing from a manuscript where you could see that this person is experiencing photophobia and a throbbing percept from the head pain. The only features of the history that are sometimes hard for kids under, say, 4th or 5th grade, 9 or 10, features of time. Sometimes it's a little hard for them to be able to estimate hours or how many times per week or how many times per month something's happening. That's something that maybe is going to have to come from the parent if they're under 9 or 10. But above that, they can really even do that part. So here, I think, is the way to distinguish between migraine and tension type headache. Migraine is much more than a headache disorder. It's really a brain-based amplification and distortion of perception of stimuli disorder. And you're going to have sensitivity features to it. Whereas tension type headache is not, in my opinion, is not a brain-based disorder. It's really more of a musculoskeletal etiology for this, and tends not to be as severe and not as likely to present to clinical attention. There's a very interesting study in adults coming to primary care setting for recurrent headaches. And they had them keep prospective headache diaries, and 93% of them had migraine. 3% had tension type headache, and the other 3% couldn't be classified. But it's very rare that somebody is bothered enough by tension type headache to be coming to clinical attention for it. If they're coming to talk to us, it's much more likely to be migraine. Migraine is very common in children. So here we have age on the x-axis and prevalence on the y-axis, broken out by sex. Before puberty, boys and girls are equally likely to be affected. As they're coming through puberty, we start to see girls being more likely to be affected. If we look, let's say here's age 10, that's prevalence of about 5%. By comparison, the prevalence of epilepsy in kids is 0.5 to 1%. So even by age 10, migraine is about 5 or 10 times more common than epilepsy in kids. And then the prevalence just climbs from there. Chronic migraine, which is what we call it when, and this is a little counterintuitive because you might think chronic migraine just means it's been going on for years, but it's defined as headache affecting at least 15 days per month for at least 3 months. So chronic migraine, the most difficult form of migraine, affects 0.6% of 5 to 12-year-olds and about 1 to 2% of adolescents. So the most difficult form of migraine is just as common as all forms of epilepsy in these 5 to 12-year-olds. Socioeconomically disadvantaged children are about 4 times at increased risk for developing chronic migraine, and children with migraine miss more school and perform more poorly in school than children without migraine. And so it's a treatable cause of missed school and impaired school performance. I'm going to talk a little bit about what are now called the episodic syndromes that may be associated with migraine. Think of these as what migraine looks like before it looks like migraine. So in the young developing brain, migraine might express itself a little bit differently than when you get into an older child. And I'm just going to touch upon these 2 younger ones. These used to be called childhood periodic syndromes, but in this picture sort of depicts them in the order that they go by age. Infant colic, benign paroxysmal torticollis. Benign paroxysmal vertigo is little episodes of vertigo that last for just 2 or 5 minutes, and they happen in preschool age kids who are, say, 3 years old. Abdominal migraine and cyclic vomiting syndrome, they tend to affect children who are 6, 7, 8 years old. And for abdominal migraine, it's really more about the abdominal pain. They may vomit once or twice, but it's really more about perception of pain in the abdomen. Cyclic vomiting syndrome has this very interesting periodicity, and the attacks come on out of sleep. For an individual kid, they might say, I get an attack every 6 weeks. I wake up between 2 a.m. and 5 a.m. and it's just unbelievable amounts of vomiting. Really, vomiting is the main problem. Their abdomen may also be uncomfortable, but it's really the vomiting that is the reason that they're coming to talk to a clinician, and it often lands them in the emergency room because of dehydration. So infant colic is, well, as pediatricians, you know this better than I do, but excessive, often inconsolable crying in an otherwise healthy and well-fed baby. There are these historical criteria, Wessel's criteria of crying for at least 3 hours a day, at least 3 days a week, for at least 3 weeks. And that's how it has been defined in ICHD as well. And there have now been several studies showing an association between infant colic and migraine. This is the best one. This is a prospective population-based study where infant colic status was assessed real time when they were young little 5-week-old babies, and then they were followed until age 18, and they assessed whether or not they have migraine. And infant colic was associated with about a 2.5-fold increased relative risk of migraine without aura, not migraine with aura. So I think speaks to some of the different genes involved. And when you go into multivariate modeling, that held up, interestingly, beyond some of these other things. So definitely seems to be that there's this association between having colic as an infant and migraine by adolescence. I think of this as migraine genes are essentially genes that make the brain more sensitive to stimuli during attacks and in between attacks. And when a baby who has migraine genes is born, comes out into the world, they're encountering all these new stimuli, and it is perhaps more challenging for them to manage that in early infancy before they can consolidate sleep and really get good rest. There are a little bit of data suggesting that doing things that we would do to help with a kid having a migraine attack might also help with a baby who's colicky. So advising families to turn off the lights, limit the number of people in the room, don't use noisy toys around them when they're fussy and crying, just bring down the level of stimulation, which I think is a safe thing to do. Using pharmacologic treatment in this very young population is a different question, but if we were, acetaminophen certainly has evidence for acute treatment of migraine in young children and would be usable in this age group. Benign paroxysmal torticollis, these are the diagnostic criteria for this, but this is a disorder that starts usually in the first half of infancy, around 4 or 5 months, and they get these episodes of head tilt, torticollis, and then associated often with other symptoms, vomiting, fussiness, they don't feel very well. If they're old enough to crawl or walk, you may be able to appreciate ataxia, and they're fine in between, they're normal in between. And I'm going to show you a video of this little one. You can see the torticollis to the right, and the guardian's also to the right. That's why the baby's looking to the right, but it's not a forced gaze deviation. This isn't seizure. And they're certainly not happy, and I think it's a hard video to watch for that reason. Well, it's called benign paroxysmal torticollis. I think there's a question about whether it's really benign. It is associated with developmental delay, most often gross motor delay. And I don't know if that's because of the underlying genetics or if you spend 1 week per month tilted, if it delays your ability to develop your muscles and your strength and coordination to start walking and sitting. Some infants and families with this disorder have mutations in the calcium channel, CACNA1A mutations that are associated not just with BPT, but also with hemiplegic migraine, the kind where you get weak on one side. And certainly it's a distressing disorder for the child, as we were just saying, and the family. If they're vomiting, they're often going to be left out of daycare, and then that disrupts work and care for siblings. And so it can be a really big challenge for families as well. And so we set out to understand, because this is a relatively rare disorder and knowledge about it is limited. So we set out to try to understand more about the phenotype and the natural history. And we interviewed families. This is done by Dr. Caitlin Green, one of our former fellows. And her series here is on the right, but you can see that starts in first half of infancy. Attacks usually go for several days. The frequency varies from person to person, and usually by, say, preschool age, they've outgrown the attacks, but they may then go on to develop abdominal migraine or migraine headache down the line. Here are the associated symptoms. The ataxia is really interesting if they're old enough to be able to see that. Fussy, which you just saw. They may have vomiting. Photophobia, that's certainly something we see. It's not always just torticollis. They can also have limb dystonia or abnormal trunk posture. So you can see movement disorder in the other areas of the body in some patients as well. And again, looking at this question of whether it's benign, most families had concerns about their child's development, in particular gross motor, and they noted issues and stresses that the disorder was causing for their family, and often delay in diagnosis because it's rare and not necessarily known by all clinicians. This is something that can be really stressful for families as well. So we asked the families, what would you like us to focus on in future research? And they really thought that improving awareness and knowledge about the disorder was the most important thing, followed by improving our understanding of natural history. So to honor that, I try to talk about BPT as often as I can. And I'm glad we asked them, because I would have thought they would be most interested in treatment and treatment trials, but it really seems more about understanding, being able to diagnose without delay, and understanding the natural history is what families are most interested in having clinicians know. So now transitioning a bit to migraine treatment, there's two sides of treatment. There's preventive treatment, which means anything we do to try to decrease the frequency of attacks, decrease the severity of attacks. And there's acute treatment. What do you do when you already are in an attack to try to stop it, or at least to ameliorate your symptoms? This is not really a true distinction, because some things that we do acutely might affect frequency, and some things that we do preventively might make it easier for the acute treatments to work, but it's useful to think about it as two different categories for both yourself when you're thinking about how to make your treatment plan, and when you're describing it to patients and families for what they should do. So ideally, of course, we'd have something that works in the moment and helps prevent the next attack. And when we start talking about the CGRP-based therapies, the calcitonin gene-related peptide-based therapies, we'll talk a little bit more about that goal, hopefully starting to become a bit more of an accessible reality. In 2019, the most recent treatment guidelines for migraine in kids came out. These are joint guidelines between the American Academy of Neurology and the American Headache Society. There's one for acute, there's one for preventive, and these are still our most common guidelines. So I'll be our most recent guidelines, and I'll be referring to them in going through treatment. So for acute treatment, first line things would be acetaminophen or ibuprofen. These have been studied in down to age 4 and found to be effective for acute treatment in RCTs. And the guidelines pick up that ibuprofen is probably a little bit better than the acetaminophen. So that would be the ideal first line treatment, 10 mg per kg of ibuprofen for acute treatment of migraine. What if that's not enough? Triptans would be the next thing to look to. These are agonists at certain serotonin receptors, 1B, 1D, and in some of them 1F. There are 7 of them in the US. Luckily, the contraindications to triptans are not common in the pediatric population. They don't tend to have a history of stroke or myocardial infarction or peripheral vascular disease or uncontrolled hypertension, maybe for your kids who have renal disease, but we don't commonly encounter these contraindications, which is helpful. And they've been around since the 1980s, 1990s, really for clinical use, but that has allowed for extensive study and great knowledge about how best to use triptans, mostly studied in adults, but we extrapolate that to using them for pediatric management as well. Here are the 7. I've highlighted in red those that you don't have to be able to swallow to use, because for kids under age 8, they can't necessarily swallow pills. And for kids who have a significant amount of nausea and vomiting with their attacks, going the oral route is not necessarily desirable. So nasal spray formulation for sumatriptan or subcutaneous injection, of course, that involves being willing to have a needle, but it is the fastest way to get a triptan into somebody, and it does get the highest Cmax, so you do get the highest blood level with that. Zolmitriptan also has a nasal spray formulation, so you could get absorption across the capillaries there rather than going through an oral route. if there's a lot of vomiting, or if somebody has an attack that comes on really quickly, that can be important. And then zolmitriptan is also available as a melt and rizatriptan as a melt. So if they can hold things down, but they just can't coordinate swallowing a tablet, those are good options. Some of these longer acting triptans have also been studied for menstrual related migraine. That drop in estrogen around menses is a very common and strong trigger for migraine. And some of these longer acting triptans have been studied for that. 4 of those 7 triptans have FDA approval for use in the pediatric population. I've listed them here in the order that they got approval. Almatriptan, which comes as an oral tablet, was approved first for 12 to 17-year-olds. Rizatriptan, which does come as that melt, is actually approved all the way down to age 6. So families often like that if I can tell them that the treatment is on label. For those who are under 40 kilos, it's 5 milligrams. For those who are 40 kilos or above, it's 10. The combination, there is a combination product of sumatriptan with naproxen. I don't actually prescribe that product because it's much more expensive. I just prescribe sumatriptan tablets and naproxen tablets. It's easy enough to put them together, but that has been labeled for 12 to 17-year-olds. And then the zolmitriptan nasal spray, also labeled for 12 to 17-year-olds. And we use all, in our practice, we use all 7 triptans. It's just these ones are the ones that have FDA approval. And the guidelines certainly do recommend that if somebody's not fully responsive to an NSAID for their acute treatment, that you would offer a triptan. Combining triptans with an NSAID helps with the outcomes. The 2-hour pain-free rate is higher if you do that, and they're less likely to get a recurrent headache in the following 24 hours. So unless somebody has a contraindication to bringing in the NSAID, and I tend to favor naproxen if it's possible because it is the longer acting one and the one that was studied in these adult trials, putting the 2 together will give you, generally speaking, better likelihood of being pain-free by the 2-hour rate and less likely of having that headache come back in the next day. So here's that thing that I'm hoping you'll take away of feeling comfortable, that if you've got a patient who's not fully responsive to ibuprofen or naproxen, whatever first line NSAID they're using, that you would then feel that you could give them a triptan. And let's say, migraine is most common in adolescents and most common in adolescent girls. So if we imagine 16-year-old, 60-kilo teen in your clinic who needs this treatment, the most common prescription that we write in our practice is sumatriptan 50 milligram tablets to be taken with naproxen 500 milligram tablets, ideally together as soon as possible after the start of an attack. You might need to go a non-oral route if they have a lot of vomiting or if they can't swallow pills, and that's recognized in the guidelines. So here are some variations on that core prescription, but that same adolescent, the 60-kilo adolescent, you could offer rizatriptan melts if they can't swallow pills or they're having a lot of nausea, vomiting, the sumatriptan 20 milligram nasal spray or the zolmitriptan 5 milligram nasal spray. And people often will think that triptans only work if taken early in an attack. That's not exactly what's happening. It's simply that migraine is easier to treat if you treat when the pain is still mild than if you treat when it's moderate, than if you treat when it's severe. And that's true of all treatments, because you also see that come out in the placebo response rate. And you see it also come out with the naproxen arm in the study I was showing before. So it's not something that's unique to triptans. It's really just migraine is easier to treat if you get in there while it's still mild. So ideally, people will treat when pain is mild and hasn't yet had a chance to get up to moderate or severe, but not everybody gets that opportunity. Oftentimes we have patients who wake up in the morning already with an attack well underway. And so they have to treat when it's severe because that's the only opportunity they have. And we certainly give them triptans. And so with that in mind, a lot of times patients, about a third or a quarter of patients with migraine have aura, and visual aura is the most common form of aura. That's what's being depicted here by this artist who experiences aura. You can see the scotoma, this blurring out in the middle. And then right here, this is a fortification spectra, this jaggedy lightning type things. And aura comes from cortical spreading depression. So it's a spreading electrical wave in the brain for whatever reason, most commonly visual, which means it's spreading in the occipital cortex. That appears to be the area of the brain that is most susceptible to this. And so you get the spreading phenomenon over the course of minutes. And for the patients who do get this, they'll then say, well, okay, you said take it when the pain is mild. Should I take it at the onset of aura? Because that's, that's my warning. And it's a really sensible question for reasons that completely elude me. It doesn't seem to prevent or delay the headache part. And so while it would be safe to take your triptan at onset of aura, it doesn't seem to work in that manner. And so I tell them, use the aura phase to find your triptan and your NSAID, find your glass of water, get everything ready. And oftentimes the headache begins during the aura phase. So as soon as you feel the head pain, that's when you take your treatment. But use it to find everything so that there's not a delay. Another question that comes up really commonly clinically is for patients who are on SSRIs or SNRIs, can they use triptans? Because there's this label from the FDA saying that that this is going to raise their risk of serotonin syndrome. And because anxiety and depression are comorbid with migraine, this is a common issue that arises and can be treatment limiting if we don't think this through. So generally speaking, this should not be a problem because serotonin syndrome comes from overactivation at the serotonin 2A receptors, and triptans are very specific for 1B, 1D, and some of them also go to 1F. So they shouldn't go to that receptor. But to look at this more carefully, the American Headache Society sued the FDA under the Freedom of Information Act for the 27 or 29 cases that led to this warning. And there are two different sets of diagnostic criteria for serotonin syndrome. None of the cases met the more stringent set of criteria, and only 3 or 4 of them met the less stringent set of criteria. And so most of those cases really weren't serotonin syndrome. But even more compelling is looking at this large data set in adults where there are thousands upon thousands of people who have had co-prescription of triptans and SSRIs or SNRIs, about 120,000 people. The rate of serotonin syndrome is very low at 0.6 per 10,000 person years, which is this within the range that you see from SSRIs alone. And so you don't have to avoid triptans in people who are taking an SSRI or an SNRI. I try to remember to tell people this when I'm prescribing to them, because otherwise the pharmacist will flag it and make them nervous and make them think that I don't know what I'm doing. So I try to let them know that, pharmacists might mention this, but it's been well studied and it's absolutely fine. If they don't respond to the first triptan, it is worth trying a second triptan. This is an adult study of people who did not respond to sumatriptan, trying a different one, elatriptan, and the 2-hour pain freedom and pain relief rates are just as high as we would see with somebody who has not come from a selected population of non-responders to sumatriptan. Whether this holds up for third trial, fourth trial, fifth trial, I don't know. And we used to do that before we had CGRP therapies, because that was, what we had. But at least going to a second triptan, I think, makes sense based on this level of evidence. It is in the guidelines to do that. And from a practical standpoint, insurance is going to require at least 2 triptan trials before they're going to approve any of the newer therapies anyway. So I think it's very reasonable to try 2 triptans. And why might somebody respond to one triptan when they didn't respond to another? The pharmacokinetics certainly do differ. Some of them have shorter half-lives. You can see frovatriptan has the longest half-life. This is, I think, why it's one of the ones that's quite helpful for menstrual-related migraine. And then naratriptan, the other one, studied for menstrual-related migraine, probably the second longest half-life. And they have slightly different ways of being metabolized. And so you could see how one person's body might respond better to one versus the other. So now transitioning to the newer class of therapies, there's this very important peptide, calcitonin gene-related peptide, CGRP, that's involved in vasodilation. It's involved in bone healing, has roles in uterine and placental function during pregnancy, and is certainly released from trigeminal nerves that are involved in migraine pathophysiology. People who have migraine have higher levels of CGRP. People who have chronic migraine have higher levels than people who have episodic migraine. And that's also true in children. So here are plasma CGRP levels in kids with migraine during an attack versus not during an attack versus non-migraine headache group versus controls. So this also applies to young people. And there are different ways to block CGRP signaling. So CGRP is represented here as the green triangle, and it binds basically with equal affinity to what's named the CGRP receptor, but also to the amylin-1 receptor. So shown here is other receptor, but it binds to both these receptors quite well. So you could either block the ligand, block the CGRP itself. So you could have an antibody that soaks up the CGRP itself, or you could have something block one or both of these receptors. And we do have treatments that block what's called the canonical CGRP receptor. But when you're doing that, the CGRP still exists and is still able to go signal at the other receptor, just to know. So now we have 4 monoclonal antibodies to CGRP or its receptor. One is to the receptor, the other 3 are to CGRP itself. These have been out now for, well, about 5 years. Yeah, here we are in May. So 5 years. These 3 are done by sub-Q injection at home. And this one is done intravenously in our infusion center every 3 months. And when I was first starting to prescribe these, I was curious, how much IgG am I giving to a patient? Is this like giving IVIG, or what is this? So this is a very helpful little math fact for me, that 1 milligram per kilogram of IgG represents 0.1% of our body's total IgG load. So if we take the 70 milligram dose of arenumab and you think, okay, this is a 70 kilo adolescent patient, that's essentially 1 mg per kg. So I'm giving them 0.1% of their body's total IgG. So it's not a huge amount. It's not like giving IVIG. And when these were coming out, a group of us from the American Headache Society and the Pediatric and Adolescent group got together to think about when might we use these in young people. And we thought through, well, as much as we think these are probably safe, they have not been formally studied in young people. So we'd want to make sure that they had tried at least several other more conventional therapies. Ideally, they're older, not giving this to younger kids. They have a significant headache problem with a significant disability score, and we don't have any reason to think that they've got a lack of integrity of the blood-brain barrier. So thinking through what some of the parameters might be, and I'd say that this mirrors what we do in clinical practice. Again, logistically, insurance will not cover these if somebody hasn't had at least 2 previous preventive therapies. And I think that's actually a good thing, because it helps us really select who needs to go with what I think is a small risk, but a unknown potentially. And so what do we know so far about using these in children? There are randomized control trials going on, but we've been using them off-label in our practice. And we came together with 2 other pediatric headache programs, Denver and CHOP in Philadelphia, and just wrote up our experience as a chart review study, essentially. So this is 112 adolescents. The vast majority of them had chronic migraine. Some of them had this other headache disorder called new daily persistent headache or persistent post-traumatic headache. And this is a population that you see in a headache program. Many of them had continuous headache at the time of starting their new prescription. They had very high baseline headache frequencies, 27 days per month. They had high disability scores. They tried a very large number of previous preventives. We said, okay, what do we see? At our first follow-up, which was around 3 months, and our second follow-up, which is around 5 months, the vast majority of them had received arenumab, because this is the one that came out first. And this is the one that blocks the CGRP receptor, but some of them had received galcanezumab, some of them had received fremonezumab. And in terms of bringing down headache frequency in days per month, 2 may look like a very modest improvement, but in this particular patient population, any movement I feel is actually really a positive sign, because it can be really hard to get things started. And then once you get things started, when you come from continuous headache every day, all the time, and you can actually get a little bit of a break, you can then build from that. So to me, that's an important difference clinically. And in terms of what they noticed, less severe headache, which is an outcome measure that kids with continuous headache really value and parents of kids with continuous headache really value. That is something that was seen in about half of them, which is really encouraging. Side effects, we want to look at safety really carefully because we don't have formal trial results yet. And about a third experience side effects: injection site reaction, redness, soreness at the site. That's the most common. Constipation is probably the most troublesome. And 8% experience that. Usually we can treat through that with diet or Miralax. And then just a handful of other observed side effects. And eptinezumab, which is the infusion-based one, we have been using that in our infusion center. I'm just showing that this has been used. It's a small case series, so I don't think it speaks too much to over and above what we just reviewed. There are also now small molecule blockers of the CGRP receptor. These are called GPANTs. This is like a pill that you would take analogous to taking a triptan. And there are 3 out on the market now. Abrogepant, which is available as a 50 or 100 milligram tablet, Rimegepant, which comes just as a 75 milligram oral dissolving, and atogepant, which comes in 3 different pill sizes. Interestingly, these medicines really do help with that acute and preventive concept, because these 2 have been studied for acute treatment and these 2 have been studied for preventive treatment. So there's crossover there, and this has a longer half-life than this one, so that's probably why it's also helpful for prevention. But if you can block this right in the moment, that's great for that current attack. If you can block it for a longer period of time, that's great for preventing the next attack. So you can start to see that really nice crossover between acute and preventive treatment. Just to know, there's also a 4th one, a nasal spray form called Zavegepant, that will be coming out in July. It just got its FDA approval. And unlike triptans and some of the other acute medicines, we don't have to worry about medication overuse headache here. That doesn't seem to be medication overuse headache for some people. Overuse of certain acute treatments can paradoxically drive up the headache frequency. That doesn't seem to happen with this class of treatments. We know from the monoclonal antibodies that the more you block, the better they do from a preventive standpoint. And so we don't have to limit use of this from that concern, which is really nice. However, these are newer medicines. They tend to be more expensive. Often you're still limited from a practical standpoint by how many tablets insurance will cover in a given time frame. So this is showing the 3 that are currently on the market, their dosing, their half-lives. They're all going to be expensive. They're all hepatically cleared. One thing that's really nice is that there are not a lot of med-med interactions unless they're on some sort of antifungals, which aren't terribly common in our patient population. So we don't usually have to worry about that. And they are very well tolerated. In the adult trials, about 2% had nausea, 2% had fatigue. That's also seen in the placebo arm. I think that is probably essentially from migraine itself. But and in our clinical practice, I would not say that we're seeing more than that. So these can be, I think, a really helpful tool for people who don't respond to triptans. On the preventive side of migraine treatment, clearly this is complex, and there's a number of different angles that one might come at for this. The best evidence is the combination of cognitive behavioral therapy with amitriptyline for migraine prevention in 10 to 17-year-olds with chronic migraine. So that's certainly a very commonly used first-line treatment in our practice when we see people for first-line treatment, but certainly we are often going on to second, third, fourth, and fifth-line therapies. But something that I think is really interesting to think about is, where does the responsibility rest for decreasing migraine frequency? Is it with the clinician? You know, as a migraine doctor, I certainly think that this is my responsibility. But you know, does it rest with the patient and the family? Are there things they're supposed to be doing? And what about society? Does society have a role in helping to bring down migraine frequency? So in the guidelines, they say that we should be counseling patients about lifestyle and behavioral factors that may influence headache frequency and things that may contribute and be potentially modifiable. These often come out as, people call them healthy habits, like regular sleep, regular meals, regular hydration, all those types of things. It's a very deeply ingrained practice in that CHAMP study, the one that led to our understanding about placebo response rates in kids with migraine. You know, at every visit, they also got instruction around doing these healthy habits. But I think it's, sort of asking kids to walk a tight wire, and I reflect on my own day. I wake up at different times, and sometimes I don't quite get breakfast. It's asking them to live a pretty rigid lifestyle, and that's okay if we're sure that it makes a difference. But if we're not sure, then maybe we don't need to be pressuring them in quite the same way. So you could say, well, this is all healthy advice. Why wouldn't you say this? And I think if you're counseling it for someone's general health, by all means, exercise is definitely very important for general health. But to tell them it's going to make a difference for migraine, I think that needs to be an evidence-based statement, just like if we're going to prescribe a medication to them to help with migraine frequency, because we do get these calls all the time from families wondering, can they go on the school trip to Washington, D.C.? That's going to throw off their sleep. What about summer camp? Can they go to summer camp? So it's things that are normal child behaviors and choices that I don't think we should be curbing if we don't have to be curbing. And my colleague Sam Irwin and I sort of took this on in what was meant to be provocative. I'm happy to send you, because I think oftentimes we're operating on slim amounts of evidence for whether or not these things make a difference. And some of these are not necessarily modifiable. So sleep, I think, is the most interesting area to look at in this space, and this is where I would be most interested. And if we think about adolescent sleep needs, they can't fall asleep before 11 p.m. generally. That's why the AAP recommends that high schools and middle schools begin no earlier than 8:30 a.m. because they need to get adequate sleep. But many schools, at least before, California is the first state in the union to have a law that high schools begin no earlier than 8:30 a.m. that went into effect this school year. At least before that, many times they were starting early. And so we're sort of physiologically introducing pathophysiologically shortened sleep because we're making the kids wake up too early. And so we looked at this, thinking, if your school is following AAP guidelines and starting after 8:30 a.m., do you have a better headache pattern than if it's not? And we recruited high school students with migraine living in the US and surveyed them online to look at this. We got about 500 per group, 8:30 a.m. or later versus before 8:30 a.m. And you can see that those with an early start school did have a higher headache frequency, about 8 days per month versus about 5 days per month. Certainly they started at an earlier time because they're batched that way. And those who are going to a late start school were more likely to get at least 8 hours of sleep on a school night. And so unadjusted, we're seeing about 3 days of headache difference between these groups. And just for comparison, whenever in a big pharmacologic trial for migraine prevention, the mean difference between active and placebo tends to be around 1.5 to 2 days per month. So even after adjusting for sleep and homework and all these other sort of things, there's still a difference in the late start versus early start that's close almost to what you might see in a pharmacologic trial. So from that standpoint, if this really makes a difference, this is not something that necessarily a family can control. They could go advocate with their school board if they, don't live in California and have this law, but it's something that's really a societal level intervention that, if replicated, if true, could mean thousands of fewer migraine days for kids over the course of a year. So to summarize, when you're seeing a kid with recurrent headaches, you want to make a specific headache diagnosis. It's not chronic daily headache. That doesn't give you a specific diagnosis. You're trying to come to either migraine, tension type headache, headache from a systemic viral infection, whatever it is. And migraine is going to be a very common reason that kids and adolescents are coming in to see primary care, because this really is a disabling headache disorder. Before it looks like migraine, it might look like something else, infant colic or benign paroxysmal torticollis or abdominal migraine. For acute treatment, NSAIDs are first line, but if that's not enough, NSAID plus triptan. And for preventive treatment, really thinking through the complex issue that could be its own talk, but what matters in lifestyle, what doesn't, what matters for pharmacologic therapy, what matters for cognitive behavioral therapy, and other steps in that way. I'm happy to take questions, and thank you so much for your attention.
Thanks so much, Amy. I think we've all many amongst this group in the talk have had migraines experientially, so this is actually really helpful. I will throw it open if anyone has questions to ask Dr. Gelfand, and you can either just unmute yourself and shout it out or raise your hand, and I'm happy to moderate a little bit.
Looks like there's a chat too. If I don't know if the chat function's another option too.
Good question. This was super helpful. I'm wondering for the abortive meds, if you want to give it as soon as possible to try and, catch it before it gets severe. If you start with just an NSAID, then don't you have to wait like however many hours, like 4 hours or 6 hours before you can then do a triptan and an NSAID together? And I know it's sort of technical, but how do you advise on that?
Yeah, that's a really good question. So, and sometimes it matters a little bit what the patient's frequency is. So if they just have, let's say they have 3 attacks per month, I would tell that patient, treat with both as soon as it starts. Just be aggressive and shut it down immediately, because they're not going to run into any problems with medication overuse headache from using triptans 3 times a month. That's not going to be a problem. So I would encourage them to just be as aggressive as possible right at the get-go. If they have more frequent attacks, we'd be working on that from the preventive side. But in the meantime, let's say they're having 10 days per month that they need to treat. That's a little bit of a trickier situation because you don't necessarily want them to be taking triptans, 10 or more days per month. So then I might ask them, can you tell at the get-go if it's going to be a bad one? And some of them some can tell right at the start. And I'll say, then for those bad ones, you take your triptan and your NSAID right away. If it's a minor one, you can just take your NSAID. Some of them can't tell, and they have to just see what happens. So for that situation, if they got frequent attacks and they can't tell if it's going to be a bad one, say take your NSAID right away. And as soon as you realize it's going to be a bad one, or you need to get more relief, add your triptan. So if let's say they took their naproxen at 8 a.m., they could add their triptan really at any point. You're right that they don't want to redose their naproxen right away, but I consider them covered from the combining benefit standpoint for, at least 8 hours. So they could just add their triptan at whatever point that they realize they need it.
Thank you so much.
Yeah.
There's a question in the chat that says, do you have an upper limit of days per month of using abortive therapy before adding the preventive therapy?
Yeah. So, from when to offer a preventive treatment, if somebody has 4 headache days per month or more, I usually have a conversation with them about whether they want it. Not everybody will at 4. They might only want it if they had 6 or 8, but if it's 4 or more headache days per month, I usually will have a conversation about the option of preventive treatment. With regards to using ibuprofen, NSAIDs are really interesting in this medication overuse headache quandary. NSAIDs seem to be a little bit special in that they seem to have very little likelihood of causing medication overuse headache. If you look, the guidelines will tell you to limit NSAIDs to fewer than 15 days per month. From a medication overuse headache standpoint concern. And certainly if you have GI or other reasons to worry about that also makes sense. But it doesn't seem that NSAIDs are very likely to cause medication overuse headache. So I don't limit my patients in how frequently they're using NSAIDs, but other people might have more level of concern for that. Effectiveness for migraine prevention, MAG and riboflavin. Yeah, so oftentimes people for first-line migraine prevention, oftentimes both myself as a clinician and families would like to try something that's on the more natural side of things. And so riboflavin, which is vitamin B2, we very commonly recommend. The adult RCT for that was 400 milligrams daily. And that one I do really like to use. Magnesium also has some evidence for migraine prevention, but I find that to get to an effective dose, a lot of times they're getting loose bowel movements from the magnesium, but we do sometimes add it in. particularly if somebody's getting constipated from their CGRP monoclonal antibody or constipated from amitriptyline, adding some magnesium can help with that. And sometimes we'll have them take it in the evening to see if it might also help with their sleep. But I use it more as an assist than their primary preventive. And second question, migraine with aura and estrogen use. So young women, meaning women under the age of 45, have a twofold increased risk in ischemic stroke compared to those without migraine with aura. That's still a very low absolute risk because the baseline risk is low, but you can increase that risk further by smoking or by taking estrogen containing contraceptives. However, that OCP data is from when OCPs had 35 micrograms of estrogen in them, and now we have all these nice 20 microgram or even lower potentially options. So I haven't seen anybody show that 20 micrograms causes the same amount of risk. Could it? Yes. But I think this is something where you got to have a conversation with the patient and the family, because certainly other things raise stroke risk too, like pregnancy raises stroke risk. So, everything is a risk to benefit conversation. And if they need to go on an estrogen containing contraceptive, I think it's okay if they have migraine with aura. I just say, let's go with the lowest dose of estrogen that gets the job done. And it's a really good question about whether the number of aura attacks influences that risk. Not known. I would guess that it probably does. That if you've had aura once or twice, that is a lower risk than if you have aura twice a month, but it's not known.
Amazing. Thank you. I think we have time for one last question. If anyone else has a question.
You can also email me. I'm happy to field any questions by email too.
Hey, I think we're good. Thank you so much, Dr. Delphin, for coming to speak to us today. It was
Pleasure.
great to see you.
You too. Thank you so much for having me.
And thank you everybody for joining. I hope you have a good Tuesday. Take care.